I just want to say thank you to everybody for coming bright and early. We came to sunny Queensland for the warmth and it's freezing. It's, inside it's a bit okay. Also want to really say and acknowledge the hard work of the Improvement Foundation team in bringing this together today. So Katie and Ralph and all of the team, there's a lot of behind the scenes work that goes into every presentation. And we get here on the day and it's like, that looked like a breeze. But truly it's the effort of this organisation that identifies in primary health care and general practice, and look, a room full of nurses. So how about a round of applause for the Improvement Foundation? Fabulous. Now, who is actually doing person-centred care planning in their practices? Yep, excellent. So all of those people with their hands up are going to participate in this discussion. And all of those who didn't have their hands up, I want you to actually ask questions of each other, yeah? So we're away. Okay, learning objectives. What we'll look at is, because we are focusing on cardiovascular disease, we'll have a look at an overview, the person-centred care, the actual care plan itself, collaboration and what this means. Who do we collaborate with when we do care plans? Oh, that's wonderful to hear. Often we say, the allied health practitioner, but definitely the patient's a really important one. And we'll have a look at the business of cardiovascular disease as well. If you have, as I said, any other questions, please ask as we go along. So cardiovascular disease in Australia. This is really important that we get this context. In 2011, 45,500 deaths were attributed to cardiovascular disease. That's a lot of people in 1 year, isn't it? A lot of people. In 1 year alone, 482,000 hospitalisations were as a result of cardiovascular disease. When the person has a cardiovascular event and they don't actually die as a part of that, they're often left with considerable disability for the rest of their life. And if it's the rest of their life, it's the rest of their family's lives. So this is a significant illness. We also need to remember that in socio-economic disadvantaged groups, in Indigenous groups, and outer regional and remote populations, we have higher risk of mortality with cardiovascular disease. That is the same with most chronic illnesses. So anybody working with the Indigenous populations in the outer regional areas, we really need to think about who the people are in our practice and presenting to us that may well have undiagnosed cardiovascular disease. Yep. Because once it's in the file, we're kind of like, so we can handle this. But a part of our job is to actually find these people, identify them when they're coming in for something else. So how do we identify? It must be in the past history. We've all got that point, haven't we? If it's not cardiovascular disease in the past history, then it is not on your database. So it is not going to come up in any searches. It means that your information in your database is not correct. And when we do care planning, this is the perfect place. I always do this with care planning and with the health assessments. Perfect place to update that file completely. So you need to look for cardiovascular disease and get it in the past history. The groups of people that are often the ones that we've identified illnesses, but not yet have we actually put in the past history their cardiovascular disease. So these are people with diabetes, renal disease, obesity, mental health illness. And I'm going to say that again, mental health illness. We kind of label and stigma and put this person in this other bucket over here. Mental health illness, it's a comorbidity. It is really important. People that are on antipsychotic therapy, there is a lot of research around that tells us about the risk of cardiovascular disease in this group. And before we commence antipsychotics, it's suggested that we do the ECG, and we annually do an ECG. So really important group of people. Pathological lipid profile. Impaired glucose metabolism. I mean, this is really interesting stuff, isn't it? And I'm sure that you've all learnt and realised over the last few years that as soon as that fasting glucose gets, like to 5.6, we have increased risk of cardiovascular disease and cardiovascular events. So it doesn't have to be diabetes. Yep. So if you've got somebody with an impaired fasting glucose, I want you to look at that person to see whether or not, and how are you going to identify if they do or do not have cardiovascular disease. Positive family history. How easy is that? We've got the family history in the file. If there's a positive family history, we need to investigate this person. Indigenous populations, we've spoken about them. People over 55. Really, for me, I think, if Indigenous populations, it's more like 35. And other than that, I kind of think that we need to be looking at 45 and even 40. Yep. So I had a chap one day, 45-year-old, 44 he was, really fit, healthy guy, and he came in with a sore elbow. And he was seeing the registrar, a real hotshot registrar, this guy, and it's kind of like Friday afternoon at 4:45, and I'm unloading the steriliser and it's ready to hey, my time management skills today have been perfect and I want out this door kind of thing. And the hotshot rings and he says, "Ros, are you doing ECG?" And it's like, "What? You got to be kidding." He says, "Just do it for me, will you?" And it's like, "Yep, okay." So get this guy up on the bed, 44. Rides his push bike to and from work, which is 10 kilometres. Really fit and healthy. His dad has diabetes. His dad had a heart attack and died at 56. His brother has diabetes. Both have been obese. His brother had the heart attack at 53. And this guy decided he was not going to get this. He watches his diet. He's been exercising. Everything about him's healthy. So it's like pain in your elbow. Is it a work-related thing? Oh, no, he says. Every desk at our workplace is set up individually by an occupational therapist. Wouldn't it be nice to get a job there kind of thing, what about, when you play tennis and stuff? No, it's not that. He does some weights at the gym, but he stopped doing that because he did feel it aggravated it. Still riding his bike, but sometimes he feels that he's getting a little bit tired. And so I just keep on, asking questions as we're putting all the leads and everything on. And every single question and every answer he had was no, no, no. And all of a sudden I got that gut feeling, It kind of happened. And it's like, this is going to be a positive ECG. And so we'd been chatting away, hit play on the ECG machine, get this beautiful ECG, anterior ischemia, lateral ischemia. It was just like... And he said to me, what's the matter? And I thought, he's got telepathy too, this guy. And I said, what do you mean, what's the matter? And he's like, well, you stopped talking. So he identified my body language, that something was up. And it's like, yeah, let's get the hot shot around here. And now it's 5 o'clock on the Friday afternoon. There ain't no cardiologist in their rooms at 5 o'clock on a Friday. Yep, not in downtown Nowra. So the point is that there was a positive family history, a very strong positive family history. And yet, because in general practice we're so focused on acute care, in and out, in and out, in and out, this guy had never actually been picked up. And it was just lucky that that elbow pain that he had for 2 weeks was enough to bring him to the doctor. And it was just lucky that that was the hotshot registrar that day. Yeah? Because that could have easily been missed and sent out the door to take some non-steroidals. Yep, easily. So think about all the people. Think about everyone that comes into your rooms. Think about everybody. Is this person potentially one with cardiovascular disease? Can I save this person from significant disability? Yep. So, COPD, we often don't think about that. If you've got COPD, the right side of your heart is affected. Likely that you've got some hypertension. Yeah. Strokes are cardiovascular disease. And also think about autoimmune disorders, corticosteroids. All of these things. Think about, as I said, everyone. Oh. Okay. Beautiful photo, isn't it? Shining the light on the person. I really quite like it. This is the escarpment at the looking from Albion Park in the Illawarra up on the escarpment. Just an absolutely gorgeous area that I live in. So a person-centred model of care. This is McCormack's model. So it's about providing for physical needs, having a sympathetic presence, sharing decision-making. It's about engagement, working with persons' beliefs and values, and all of that, if we achieve that, leads to satisfaction with care, involvement with care, feeling of well-being, and creating a therapeutic culture. That's a nice model, isn't it? Yeah? Do we all agree? Is there anything missing from that model, maybe? We're really good at this, aren't we? Very good at providing physical needs. We're pretty damn good at having the sympathetic presence as well. Shared decision making. Goal setting comes into engagement and working with. It's always the theoretical models never actually use the words that we want and we're familiar with. You have to, dig deeper into them to work it out. But shared decision making, are we good at that? No. We like to tell people what to do. And people they like us to tell them what to do. It's a two-way thing here. Yeah? We have to help our people realise that they are active participants in their healthcare. Sorry, I'm going to keep blocking your way. Engagement?
I think education is missing because sometimes patients don't know what they don't know.
And absolutely, it's like goals. Engagement is where education comes in. Yeah? So, a model is easy to put on as a picture kind of thing, but you should see the paperwork that goes with this thing. Like it drives you bananas trying to get through it all and stuff. So, engagement, are we good at that?
I think we're better at it than a lot of the doctors because we make more time.
Yep.
And we get more of a relationship with the person.
Yep, we do build relationships that differ at times to the GPs and the GPs' relationships. We hear this a lot from nurses. The patient tells me stuff they wouldn't tell the GP. But guess what? They tell the GP stuff that they wouldn't tell you either. So it's all about a team, yep? That's the really important thing, that we have a team. So engagement, they come back. But are we actually improving things? Are we improving the health literacy? Are their numbers getting better? Are they feeling happier? Are they more involved in their care? Maybe not. Sometimes, as Debbie's saying, but maybe not all the time. It takes a lot of time and effort, doesn't it? What about this working with beliefs and values?
Engagement depends a lot on
Who has time for that in general practice? Like, Truly.
Well, if you don't work with it, you're not going to have any success.
Absolutely. If we don't look at all of these factors, we are not going to fully succeed for this person. It's really hard not to say patient, yeah? But what we know is that the health consumers find patient as disabling, you know, as the sick person or the cholecystectomy or the diabetic, yeah? So we try to use the language, but there are times where patient slips out after 30 odd years of nursing, and there are times on a slide where it just doesn't work if it's person. But, you know, it's really interesting, and it's how are we going to make, you know, how are we going to achieve these things that we're not necessarily as good at as what we could be when we're doing care planning? Because what's something about care planning that we all kind of, I'm sure, will agree with? What's the drag about care planning? What takes the time about care planning? Paperwork. Paperwork. So we get drained and think to ourselves, bloody, yep. So how are we going to bring it all together? So really importantly, so all the hands, I want them to go back up again now. Who is doing person-centred care planning? All the hands nice and high. So the templates that you use, are they heart disease, diabetes? Yep. It's interesting, isn't it? All the medical software has disease-specific templates, disease-specific goals. Jane?
I've set up with practice a multi-condition one, and then it's got a care coordination section at that. And then we've got goals, but it's cumbersome, it's time-consuming, it's really, you know, you want that checklist for the medical conditions, but also you want the
yeah.
set of goals.
It's really hard bringing it all around, and whichever template you come up with, you need to use that. That needs to work with your style, and it is really about your interaction with this person that is about the person-centred care. But if your whole care plan and your templates are driving the, you know, lipid profile to be at this particular level, you are not focusing on the person.
I was just going to say, in my clinic, we work really well as a team, so often the patient will see the GP with me as well, so we actually do look at the patient individually.
Yeah.
And then I'm always, like that lady said there, you know, you're always changing the care plan. We don't have one just for diabetes, one for chronic heart, one for, you know, chronic kidney. We don't. So for me, it is, and I think I'm fortunate that I have that opportunity to do that.
Yeah, absolutely. So when you say that yourself and the GP see the patient together, is that throughout the care plan or just at the end, or
So at the
is there
beginning,
at the beginning?
Yeah, when we're in that plan, when we're setting those goals.
Yep.
So that initial stage where we're talking about, you know, what does the patient want?
Yep.
What expectations we have? How are we going to help that patient achieve?
Yep.
You know, so it's at that beginning stage.
So you're setting the goals at the beginning before the assessment.
So, yeah, well, I know what you're saying. Yeah.
Like
So we're
I
doing-
wouldn't,
yeah,
I'd find that hard.
Yeah, so the GP does the assessment bit,
Right.
and then I'll go in and we do that bit together.
Okay, yep, fabulous.
Yeah.
See, there's all different models, and this is what's really important. It's the practice that you work in, the philosophy of the practice, the patient demographics, it's the GPs, it's the nurses' experience. Everywhere. I'm sharing a model that I use and that I like, but everywhere you go, things will be a little bit different. And we have to be adaptable, don't we? In general practice in particular. I mean, we had to be adaptable wherever we've been, but you work in a general practice and sometimes you've got 10 GPs and they all want something different. You've got to be adaptable. So it's not disease focused. I'm not doing a diabetes care plan. I'm not doing a cardiovascular disease care plan. I'm doing a care plan for a person with an illness. Person-centred care planning is about listening to that person, not telling. It's about uncovering their needs, and often at this stage they don't even know that they're needs. Yep. It's about discovering what influences a person. How are we going to motivate change if we don't know what it is that actually impacts on their life? Yep. It's about improving their health literacy. And as I said, it's not just about, do you understand what a myocardial infarction is? This is all about, you have cardiovascular disease, and that means that, you have this and you're at higher risk of that, and these are the important things. It's about teaching and learning and educating the person on the whole illness and how it can impact on them and their family. Yep. So if we're not doing this, we're not going to get there. So once we've got all of this, we're going to motivate sustained behavioural change and develop the long-term relationship. So there's no sense in you doing the care plan today and in 3 months' time you're doing the review and in a month's time you're doing the 9-7. Why do you build this huge relationship with a person when you're doing a care plan to never see him again or see him in 12 months' time? That's not a long-term relationship. That's not sustaining behavioural change. Each person has a different approach. That person becomes your patient as well as the GP's patient. That's what general practice is so good at achieving, team-based care. And the team starts with the GP and the nurse, and they need to collaborate. So this is where all that shared decision-making, engagement and working with beliefs and values come from. This in particular is identifying the person's beliefs and values, isn't it? Yep. This is about engagement, and this is also about shared decision-making. These are the important bits. So I think we're going to have a look. Oh yeah, what is a care plan? Tell me, one sentence. What's a care plan? Plan of care? Describe your care plan. So GP's still going to get to tell the patient what to do.
His request, patient's wishes were first.
Yep.
And their points of view of their care.
Yep.
And understanding what their care is and how you're going to assist them to achieve it.
Yeah, that's a good one. Sorry? Planning the health journey together. Yes, sorry, I tripped on that. Yep. Planning, these are all components, aren't they? These are all bits and pieces of it. But what I think a care plan is a comprehensive biopsychosocial needs assessment. Yep. So if you use this terminology, first off, you have to agree with it, but if you use this terminology in your practice, do you think that you might maybe get a bit of a change in thoughts and philosophies and around care planning? Because this is what it is. It is a comprehensive biopsychosocial assessment. It's getting and gaining a commitment to authentic goals. And what's an authentic goal? It's patient goals. Yep, it's the person's goals. It's about the education in the self-management. It's the pathway of care for the next 12 months. And it's about the collaboration with the multidisciplinary team. Yeah? So all those things that we've talked about. What's a review? Well, it's a brief biopsychosocial assessment, isn't it? Yeah? What we're doing here is reviewing the progress towards the goals. We're helping with the self-management education. We're tracking the referrals. Doesn't it nut you off? that they've been, but there's no letter come back. So you've got to do this. Somewhere in the process, you've got to have the time to do this. It's about completing cycles of care if there are other comorbidities. And it represents the quality of the chronic illness program. So if you do a care plan and 12 months later you do another care plan, and another 12 months you do another care plan, is that quality? We're not seeing them in between, seeing how they're progressing. We're not moving them forward. We're not assessing and then saying, hey, all that stuff that I've done so far for the last 3 months, that hasn't worked. We're not getting anywhere here. I need to change tacks. Yeah? So there is a difference. But a comprehensive biopsychosocial assessment, and I'm really keen for you to adopt that if you agree. So just to look at the MBS. So we all know to have a care plan, you have to have a chronic illness for 6 months or more, yep? Anything else? Yep, so this is just about what makes you eligible.
If the GP sees it will benefit the patient having a care plan.
Fabulous, Jane. Thank you so much. So this is a really important point. Oh. In 2010, Medicare acknowledged that there was a discrepancy between what they said a GP could do and what the clinical guidelines said a GP should do. And they went, uh-oh, we can't do this because that opens us up. We are not clinicians. So it's the clinical decision of the GP. So yes, it's heart disease, diabetes, all those kind of things, terminal illness, but it's also, you know, those people that, you know, have an incapacity to self-care, that need the support, that need a multidisciplinary team to help them, yeah? And it opened the door, whereas previously we were very strict on saying that it wasn't for mental health and it wasn't for intellectual, physical disabilities. It wasn't for... Obesity's not an illness. So let's wait till they've got full-blown diabetes and had heart attacks and they're disabled for life and they've cost the health system hundreds of thousands of dollars and it's going to be ongoing. What a load of rot. An absolute... Is that person-centred? So we're going to wait till you've, you know, experienced all that stuff? Hypertension, increased lipids, you know, impaired glucose, impaired liver function tests. What happens when you develop a fatty liver?
Sorry.
No?
I just made a noise. I just went...
Oh. So what does a fatty liver lead to? Leads to cirrhosis. What does cirrhosis lead to? Liver cancer. Yep. So all these things that might not be textbook illnesses are really impacting on our population. Oh, it's got high BP there twice. You don't know how many times you reread these things and you just don't see. So what I'm not trying to say that every single person that's got a fasting glucose 5.6 or a blood pressure of 145 on 90 is going to have a care plan. But the person that's going to benefit from the multidisciplinary team, definitely. The person that's going to benefit from your education, from the GP input, from closer monitoring, these are the people that we need to get. And as I said earlier, mental health, mental health, mental health. A mental health care plan is about getting somebody to a psychologist, yeah? It is not about the physical needs.
And credentialed mental health nurses.
Sorry?
And credentialed mental health nurses, not just psychologists.
Oh, yes, thank you. Thank you, very good point. They are like hen's teeth, but they are absolute gold. If you ever have the opportunity to work in a practice where there's a credentialed mental health nurse, it is amazing. It is a very different kind of, you know, environment to work than if you're doing it all yourself. So a person with a mental health illness needs to have their physical illness managed. They have reduced capacity to self-care. We heard that antipsychotics have increased their risk of cardiovascular disease and diabetes. They may be living in a service. You look at their feet. They've had fungal infections for years. Their shoes are falling off. You say to the service, they need new shoes, we can't afford it. You refer this person to a podiatrist who writes to the service, says you need to get this brand of shoes, and they go and get them for them. Yeah? We need close monitoring for these people as well. We need to look after the physical side. It's really, really important. Now, we won't be able to go to the hyperlinks today. There's two, but I've actually got the URL for the most important one that you're going to have to look at. So the requirements, and here we go with our two providers. The usual GP, so it's not the skin cancer doctor that's seeing somebody and freezing, skin cancer for the first time. We need to document the consent. Needs to be a written plan. Person-agreed goals, ongoing providers. If you send somebody to a dietitian for a one-off appointment, that is not an ongoing provider. Yep. They have to be ongoing. But if you send them to the dietitian once a year, every year, that is ongoing. Who are the two providers that are ongoing in most people with chronic illnesses? Say again. Podiatrist, physio, GP, pharmacist. They've got to go and get the scripts. And who else? Practice nurse, yep. But this, we're thinking outside of our practice. The optometrist. If you've got cardiovascular disease, you get a bulk billed appointment every year. If you have diabetes, anything with your eyes, every year. Don't worry about what the cycle of care, that's the minimum standard of care. But you must collaborate with these other providers. But a part of the health literacy is to ensure that this person is seeing the same pharmacist. Otherwise their tablet colour changes and it's this and it's that and they don't know what's going on, yep? And we will talk a little bit about collaboration. So 3 to 6 month review, 12 to 24 month care plan. We need to look at our clinical guidelines because our clinical guidelines tell us to review every 3 months and renew every 12 months. So unless this person is really very stable and not requiring this more important kind of review at a more regular basis, it is 3-month reviews, it is 12-month care plans. You need to put in your notes why you're doing the review at 3 months and why you're renewing at 12 months. That can be, unstable angina, blood pressure monitoring.
So at 3 months or 6 months or whatever, could you be could the GP then put a 10907 in?
At 3 months, at 3 months it's 732 by 2 because remember we're reviewing the GPMP and the TCA, yeah?
So could you do in between if you wanted then? Yeah?
9 sevens?
10907.
Absolutely, yep, absolutely. And we've got a plan towards the end that shows the way that I tend to map it out for the year and use it, yep? Very important. I don't like using 9 sevens with 732s or 72123s. I like them practice nurse item numbers. Yep, I know it goes to GP, but I get very cross if a GP slips one of those through because I've planned out the 12 months of care here, yeah? I don't, get up in their grill kind of thing and give it to them or anything. I just say, I was hanging on to that because this is, what I thought we could do and. And exceptional circumstances, we all know about exceptional circumstances. It's where you can do a care plan or a review within the time frames. If there is a significant change in the clinical condition or a significant change in their care arrangements, it must be annotated on the billing, and they're the words that you use back. The words that they use on MBS are the words that you put on your annotation. Yep? You don't have to say new illness or anything like that. You just have to significant change in either their conditions or their care arrangements.
You can use it for new patients that come to your practice too.
New patients only if they've come from a reasonable area away. So if you do a care plan for a new patient that was actually seeing the practice 2 blocks up, you won't get it.
That's all right, we don't have that at
No. So that is, in their instances, is not significant. But a person coming out of hospital, that's pretty significant, isn't it? Yeah? Okay. So, remember we started this section on person-centred care planning. Isn't it amazing how much information that we have to get through first before we actually get to the person? But if we're going to run a successful program, we have to have a team meeting. Yeah? And I'm a real fan of closing the practice down once a month, putting lunch on the table and getting everybody in the same room. And if you're a manager, you're not there to tell them what to do, because you want to value your staff as well. You want to ask for their input. You might know what you want, but you want to show that you value and you want to know what your staff can give to the organisation, yeah? So team meeting, very important when embarking. Just, I think if we do a chronic disease one every year is a good idea. Let's have a look at how we're doing our care planning. Anything we could do better? And this is where we're going to plan out our PDSA cycles. We need to agree on the roles of the GP, the nurse and the admin staff. No sense in me doing something if the GP is going to repeat it. Or admin staff, doing the recalls and me doing the recalls. That doesn't work. That's a waste of time, isn't it? Who's going to identify the patients? How are we going to do that? Appointment scheduling. How much time are we each going to have? When are we going to have these appointments? Do we actually have a room to run this from? Bit hard to do care plans in the treatment room, isn't it? Yeah. I worked in a practice once that we did that, and one of the GPs was a proceduralist as well, and and he used to just do them off bat. They didn't have to have an appointment for it. And I'm doing a care plan, and he'd ring and say, I want to do blah blah, and it's like, yeah, I've only just started this. And after a while, when he felt time was up, he'd just come on in through the door with his other patient and say, you've had enough time now. It was really quite cute. It took us a couple of months to work that system out. Because interestingly, this is the best ever person-centred GP that I'd ever in my life worked with, ever. So it was tread lightly in the slapping around business, yeah. So who's going to look at our database? What template? How are we going to get rid of the disease-specific templates? And who is going to organise the recalls? For me, I think it's a waste of my time, and it's a waste of money for the practice to pay me, $40 an hour to sit there and do recalls. When there's a receptionist sitting there that's very good organisation skills. And I like it when each GP has their own receptionist who cleans their room, who restocks their room, and who manages their recalls. It's that teamwork again. Oh, it's fabulous. It works so well because of your reception, your admin staff and the GP, that's 2 people chasing the recalls. And then you're sitting in the background chasing the chronic disease recalls, in that you're not sending letters and phone calls, but you're tracking them to see where your patients are up to and who's due. So setting the scene, an hour appointment. Who has an hour for their care plans? Who has a half hour? And who has 45? Okay, so the 45's kind of rule in this room. Generally, it's the half hour that rules. But if we're going to do person-centred care, we're going to need an hour. I need an hour. Yep. Sometimes the GP might have a half hour, the nurse might have a half hour. All up, it's an hour. This person needs an hour of face-to-face. You're going to arrange for no interruptions. And the receptionist, no, do not ring me when I have a patient unless I have to get up out of that chair and come out for an emergency. Because this is all about this person's appointment and focusing on them, yeah? It's not about everyone else. It's about actively listening. If you ask the same question 2 or 3 times, you've lost them. If you're not making eye contact with them on a regular basis, you're losing them. You know, they're reading your body language even if they don't realise that they're reading your body language. It's about open-ended questions. It's not like, you know, have you had any problems lately? Or you haven't had any problems, have you? You've been taking your tablets. You see what I mean? Like, these are real exaggerations, but to bring it home to you, it's really important the way that we speak to people and include them in the decisions. So I might think, oh, we've just gone through the diet and you definitely need to see a dietitian. But I don't go, you definitely need to see a dietitian. No. You know, I bring it back with that reflective, you know, communication. It's like, you know, when we were talking about your nutrition and you were saying this and you were saying that, dietitians are a really hard sell because most of the people with a chronic illness have seen in the past and they've said you can have half a slice of thick bread a day, 1 boiled egg twice a week, yeah, 10 glasses of water, you know, all this, and they don't do that anymore. So it's up to us to improve the health literacy. So this person is going to work with you. They're going to ask you, what do you like to eat? What are your favourite foods? They're going to work it out with you, yeah? And yes, we said about the including. So they're really the beginning. Before the patient's even here, see, we've gone through so many slides. You get exhausted before you even start the care plan.
Can I just ask a question? With the previous slide, with the 1 hour appointment, for those nurses who can't do it for an hour, do you have any advice that you can give to those nurses on how they can advocate?
Yeah, it can be really difficult, and it's general practice is really quite intimidating, isn't it, to negotiate with and stuff. And what I think is a possibility, if you're having a half hour, don't aim for an hour. First off, you're not going to get there. Aim for 45 minutes and sit with that for a while and then move on, yeah? If you're 45, then look to a half hour. And if you're an hour and you've got absolute bucket loads of super complex people, then you're after an hour and 15 minutes to an hour and a half. So I think it's good to use an example. So the day that you have a person that makes you run significantly late, because this is a really complex person that requires lots of support, lots of paperwork, that's a good example to use. And sometimes running really late, while we never do it on purpose, is a really good negotiation tool. Because if you're running late, so's everybody else. Yeah? But tread lightly when we go for negotiations and talk about patient need. So today, this person, you know, they had cardiovascular disease, they had renal disease. There's so many things they really don't understand, and I didn't have the time to, because I had to do all of this. And I really thought that person would benefit, you know, if I was able to do this. Sometimes you might even have to cut the appointment and not complete the care plan so it can't be billed on the day. Yeah. And it's not, we're not doing that out of spite. We're just doing that there's more people out there that, you know, that kind of need it and stuff. Yeah.
We use best practice in our practice, and that sets the scheduling. It actually sets the times in best practice. So, you know, it allows...
Change them.
We can change it,
You
yeah.
can change them. Where are you? Yes, you can.
Medical we do the bookings, of course, and quite often you'll see a care plan on there, and then they'll sneak in another little appointment just in the side there, so that 45 minutes becomes half an hour, and it's just not good enough.
And, you know, this is another key factor too. So when I talk about why I need an hour, all about the person, and I also say, you know, this is about building capacity into the day-to-day practice. If I'm so tight with back-to-back care plans and the emergency walks in, I'm not going to be able to help. When flu season erupts, I'm not going to be able to do flu shots. You know, I'm not using that language, but, you know, you've got to think about the language that you use, because as soon as you say, I'm not, to a GP, they're kind of like, well, you're not going to get a lunch break, are you, kind of thing, you know. Like, you know, it's really interesting. But, you know, we're building capacity into the practice. And the key thing that gets through is, you know, if I have an hour for a care plan just routinely, I'm going to be able to do that emergency care plan for you when you need to, you know, every so often. They're going to bang a heap of emergency care plans in on you for a while, and you've just got to cope with it because it'll come clean. They'll be right, and away you go. Yep. So think about the whole practice as well as the person.
Ros, there's a limit on how many care plans a GP can do now too, which has changed recently.
Ralph, are you...
My GP said that Medicare put a cap on it at 179. I think it is, or 149 or 179 per GP.
Per year?
Per year.
Jane?
There's the 80-20 rule.
The pharmacy or pharmacist, but I'm not aware of anything that's not the GP can do a care plan.
No.
We haven't had any rejected, and we've got 80% of around about 2,000, so we've got about 1,500 from multiple GPs.
Would you put multiple GPs?
Oh, yeah, that's multiple GPs. 4 GPs. So it's about
I'll double check that.
Yeah, because that seems to me that would be interfering with the GP's clinical decision making. And
Then there's the 80-20 rule that, you probably can explain that more, Ralph, that there's people billing more than the average GP.
yeah,
And they're looking at those people. But, you know, like, I think last year it was an extraordinary number of people, you know, billing. There was a smaller number of GPs doing an extraordinary number of GP management plans.
Yeah.
They seem to be able to do it.
yeah.
You know, it's just people reporting the system.
Yeah, absolutely. And each area and region, we saw earlier, if you're in an Indigenous area, you're going to be doing bucket loads of care plans. If you're in outer regional and remote areas, you're going to be doing care plans on a lot more people than you might have to elsewhere, yeah? Yeah, so it's interesting. But look, I have to impress upon you, before you embark on this care plan, look at the billing. The GP slipped in the review a few weeks ago, maybe a care plan, no sense embarking on this if you're not going to be able to do it, yeah? So look at the billing, make sure that you're able to do this. And then I set the reason, I get this file organised, update the reminders and recalls. I load up my template, I actually use in best practice, I put the body of the pathology into the template and stuff as well. So, you know, I need to look at that kind of stuff. I try to get all of that done. I love autofills. You know, my autofill is, you know, referred by whoever the doctor is for a new initial or repeat care plan for these illnesses, you know, recommended providers, discussed informed consent, you know, informed about potential costs. It's just an autofill, and all I have to put in is the GP's name and the illness, yeah? And I do one for the GPs as well. So use the autofills. And because what they do, as well as save you time, they prompt you to make sure that you're doing all the steps you need to do. I love them with immunisation. You know, the autofill can be this long, but you get to do women's health, you know, use your autofills. And then you have to go through the whole file. You need to get to know the person. So I start with the medications, because the medications are going to tell me what should be in the past history, yeah? Then I'll go over to pathology, because the pathology is going to tell me, is this medication regime working? And as well, have we got everything in the past history that we should have? We need to look at, you know, the last few GP appointments in case there's something new that we need to look at. We need to look at how many referrals from before, which referrals were followed up, what letters we've got back, what was the previous care plan, what was the previous review, what immunisations have we done. We need to look at the specialist letters, because sometimes specialist letters get read and the follow-up doesn't happen, or the specialist is trying to move this person in this direction, so we need to know that as well, so that we can get the specialist, you know, we can be on board there. And sometimes when you read the specialist letter, it gives you a really good in to give a specialist a call. And you get a specialist ring you back. Oh, gee, that makes your shoulders go back and you have a good old yarn. Before. Yep, those minutes before. So I have an hour for a care plan, and I'm going to start at this time. And this process, depending on the complexity and the knowledge, sometimes this might take 10 or 15 minutes. Sometimes it takes 5. But if I don't know this stuff, then I'm not going to be able to work with this person, yeah? And I'm going to, instead of being able to focus on them while we're doing the assessment, I'm going to have to keep flicking around the file. Anybody have an opinion about doing?
I try to do that also, but there's that time the patient doesn't show up. Yeah. And then how do you remember all this stuff?
Yeah. And quite often I have a whole day of care planning in syndicates I work with. And what I've done is have an hour and a quarter for all new care plans. So I've got that 15 minutes before I start. Because I need to be fresh, I need to, as you know, when that patient walks in, I want to know all that stuff. So probably it's okay to do it the day before if you're there at the practice, but also if you haven't got that many care plans. But if you've got 6 care plans in a day or something, it could be just...
Yeah.
I'll read them the day before, because if it's relevant in my mind for the next day as well, because I know that patient that well.
You know what I think too is another good point? It comes back to how much time you get for a care plan. So if you're spending time the day before, that's not been included in your time. So you're not doing yourself a favour. You know. Yeah.
You know, data entry, because patients don't like
Yeah.
Can I do it the day? I mean, I can do it at the end of the day too. That's my choice to do that.
Yeah. So that time is not being included in your, and so it's not really showing what you're doing. So to that degree, that's the negative side of doing it. Absolutely. And for us as nurses, first practice I worked in, nurses did that with their care plans at lunchtime. Yeah. And it was just expected. And so when they got good at doing it, the care plans were cut to 15 minutes.
The problem is if you start getting the care plan ready before the patient comes in, you know, the medications won't be up to date. the social history, which is so important as far, especially with care coordination.
Yep.
You need the patient there. So I find that if you've imported the template and started putting stuff in, it's actually last visits.
Yeah.
She wouldn't do that. This is about looking at immediate information.
Yeah.
I'm writing it on a piece of paper. I'm not putting it on.
Look, I suppose, I worked with, a fabulous GP who taught me to take no prisoners. So, because I used to do a care plan and have a list of things that I had to do after that person had gone. Bring the next one, take no prisoners. Every appointment, he said, you take no prisoners, you have nothing left over. You sort it all out. And then you've got to manage your time so that you can get the next one and the next one and the next one. It was the most valuable lesson that I learned in general practice, was to take no prisoners. When you walk out that door, before you bring that next person in, you have completed what is required, except for in those exceptional circumstances, yeah?
Specialist letters though, it's often better if you know the day before. I mean, sometimes you can't plan those things, but if you're sitting with that patient and trying to ring the specialist, trying to get it faxed through to you, it's not, you're out of the room to see if it's come to reception and come back.
Yeah. Well, see, in those instances, if I've sent a referral to a specialist and there's no letter of return, then I bring the patient in and say, did you see that? And they go, yep. And I'd say, right, we haven't got that letter back. So that is a prisoner that I'm going to take today, but I'm not going to do it then. It's too bad. If the specialist didn't get that info back, that's not really my responsibility. But I am going to ring up and chase that up. But I'm not going to waste my time with this person doing that, yeah? So, it can be difficult to do that take no prisoner kind of thing, but it's a fabulous way of looking at things.
At our practice, we run nurse clinics, and so we're responsible to call the patients for the next day, so we know they're coming.
Yep.
And then we get an hour in the morning to do all of that for your day. And that was negotiated.
See, that's wonderful, isn't it? So we are going to do a bit of pre-preparation, but we're actually acknowledged for it. Yep. Did we to get all of those? Yeah, go through. You really need to know this person. So I bring them in. You've got the scales between the door and the chair. So they've either got to stand on them or trip over them. And if they trip, then I get to assess their stability, yeah? So always round I'm a winner here, But this is really setting this scene of how this assessment is going to go, how you respond to what this number is. And not everybody wants to know what the number is, so don't call it out. Wait for them to ask. So what do we say? Somebody comes in and, they weigh 140 kilos. How would you respond? What would you say? Jesus, you weigh 140 kilos. How long have you been that fat?
I wouldn't. So we actually run at my clinic, we run again some nurse-led clinics, and we have a weight loss clinic that we're running at the moment. So, I'd probably try and encourage the patient to come and, be part of the weight loss clinic.
Yep. Anybody else? What would you say? Person-centred. Isn't that wonderful? This is all about their body language.
I just ask the patient what their level of comfort, what their weight of level of comfort is, and let them decide if they're too big.
Yeah.
I asked what they were last time, because they know what.
That's my key too. I say, is your weight stable? Yep. It's not judgmental. It opens up the conversation. Yep, yep. Absolutely. You just get so much information. Is your weight stable? Yeah. And I had a person that everything for 2 years had been negative, put on weight, bang, bang, bang. And it was like, I don't know how, if everybody else has tried here and nobody's got anywhere, I don't know what to do. And she came in, I said, is your weight stable? And she looked at me and she said, well, actually, no. I lost 25 kilos last year. I put 5 on. So we had to say, that's amazing. How did you do that? She's like, well, I started moving more. How can we get you back to move? Like, opens the conversation up. Then sit down in the chair. Well, you get the height and if you do the waist, it's entirely up to, each practice. Not all practices do waists once we've got chronic illness. It's an indicator of it developing, yeah? But I like the database to be complete. So, I like to do it. So sit them down in the chair, put the blood pressure cuff on and turn that screen away from them. Do not let them focus on their blood pressure, yeah? Turn the screen away. Feel the pulse. What are we feeling for? And if it's irregular, is it regularly irregular or irregularly irregular? What else are we feeling for? The pressure. And is it bounding? Is it feeble? How does it feel? Is it stiff and hard? Or does it feel a bit pliable? You can tell that I used to work in, rural intensive care, can't you, kind of thing. Love that kind of stuff. But there is a lot of undiagnosed AF out there. So do that, and by the time you've done that, and felt the pulse, you push play again on the BP monitor. Yep, so we're going the second round here. Put the oximeter on. I do a blood glucose. When I do a 72123, do a blood glucose. Yep, doesn't take very long. And then finally I'll push play for the third time. Because in general practice it is the third blood pressure that is likely to be the most accurate. Yep. Again, just sitting. Yep, unless there's abnormality or something there. Is again another fabulous GP taught me this in the early days.
Sorry, can I just ask, is anybody using HbA1cs instead?
For diagnostic.
Yeah. I'm just wondering whether many practices have.
So Ralph, a GP perspective on HbA1c for a diagnostic tool.
Look, I think it's a great idea. It certainly makes it a lot easier. The biggest barrier we had was getting people to do OGTs. They just hate it. So doing A1C is certainly an easy way of doing it. If you have an inverted A1C machine that works great, makes it even easier. We still do fasting blood glucoses or random indicating. Inverted A1C up here, all that.
And is it true, Ralph, that if you do formal HbA1c and this person doesn't actually have diabetes, they are now on your diabetes register just because you've done the HbA1c?
What I number the company is actually pushed on inverted A1C. There is an item number specifically to be used for screening.
Uh-huh.
I don't know whether the government has actually caught up on that yet.
Yeah.
If it's a different item number, it shouldn't be a problem. If they're still using the same item number, then you've got a problem.
Yeah.
Actually getting them off the register,
Yes.
even when they're not diabetic.
What did you say? You can get them off?
Quite a mission to get them
Oh,
off.
yeah, absolutely. Yeah.
There eventually.
Yeah, but yeah. So, while I'm doing all of this, of course, I'm chatting to them about their care plan, why we're doing it, why the doctor's referred for. Maybe there's going to be some costs. I'm getting the informed consent. I'm getting their buy-in. I want this person to sit there and think, oh, gee, this is really good. Gee, this is all going to be about me. This is going to be great, and I'm going to get rewards. I think this will be worthwhile. That's what we're trying to do here. Okay? We look, allergies, family history. As I said at the beginning, this is a great opportunity to actually clean up this file and get it sorted out. Yep? And then I open up medications. I turn the screen to the person and I ask them about their medications. Yep? What is it that they actually know about here? Yeah? Really important. Then I turn the pathology screen to them. And of course they're going to say, what does red mean? And you don't say red's abnormal because that's not going to help. So you just say, the pathology providers are bound legally to have to report in red something that is outside the general range of the population. And they'll go, but the doctor told me everything was fine. And as nurses, we do a brilliant job, don't we? We bring the GP into the room. We say, yes, that's because your GP has looked at your results with you, the individual, looked at your health, your age, your illnesses, your medications, and they've taken all of that into account. And all of a sudden, this person's sitting there thinking, wow, I've got a great GP and a great nurse. And this is a really big achievement for care planning. You want people to think this and to know and to trust what it is that you're saying and doing. Yep? Okay. Then we do the smoking and alcohol as well, yep, because it's often not updated either. Needs assessment.
Can you tell me why you don't include illicit substances?
Because it's coming up. See, that slide is actually about the person but the file, all of those things before the template, yep?
I don't use templates, so I'm just going to...
Yeah, no, that's okay. But you're getting the gist there. It's like we're going to do the family history, the allergies. We're going to go through and make sure that this file is up to date in that process. So rate your health on a scale of 1 to 10. Really important question. The most important question is, what is your main health concern? Yep. Because we've got them here for cardiovascular disease, but it might be the son's ice addiction. You're not going to get anywhere on the heart until we help this person with that. It might be the retired husband. Now that's a hard one to work out. You've got to try and get the hubby in for a care plan, don't you? Try and work this out. How long have you had your illnesses? You're assessing their health literacy. What do they know? Who is the person that we're potentially going to refer to from this section? Or the group of people? Yeah, you can call them allied health, but I prefer not to. Your clinical nurse consultants, your heart failure nurse, your cardiac rehab nurse. This is all about how we can connect them to the nurse. And I know the government, for goodness sakes, a few years ago said, nurses, allied health, just throw them all in together. When they started with Medicare locals, did you uproar about that? We certainly did. Some people have worked out that we're not, but not everybody. So this really here, we're looking at, is there a specialist nurse in our area that can help here? Then the nutrition. Is your diet healthy? And I go through every one of these. I write down what they have for breakfast, lunch and dinner. No sense just with that first question. How many serves of fruit and veg every day? What kind of proteins do they eat? What kind of dairy? If they say they're having full cream milk and butter, what do I say? What? Anybody got an alternate to that?
Swap it, don't stop it.
Swap, don't stop. Any other alternates? We're going to tell them to eat the margarine that's full of the trans fats. We're going to reward that. Hey, I'm not here to make a judgment. So it's like, yep. And is that what you've always done? Yep. This is up to the dietitian to sort this stuff out. I'm here to engage and connect and work out where these needs are and help this person realise their needs, yep? So I don't have to make the decisions and the judgments about what's good and what's not. And besides, Michael Mosley, just 2 weeks ago, he said it was good to eat butter. Water and salt. Do you add salt to meals? And they'll go, oh, look, I'm going to go to the other side. I will trip there. They'll go, no, don't add salt. But they put plenty of salt in the saucepan when they're cooking. In Australia, we don't need salt added to anything. One slice of bread is full of salt, yeah? So we need to help this person realise that they're going to benefit from a dietitian, yeah? Are they actually drinking any water? Are they having 3 or 4 cups of tea a day and nothing else? Or maybe half a glass with their medications? What about the processed foods? Are they buying cakes and biscuits off the shelf because they're full of the trans fats? They're the killers. Yeah? How many serves of takeaway? They might say, I only have one takeaway a week. And what do you get? I get a pizza. Oh, that's pretty good. Do you enjoy that with a fella? No, I eat it. It's all right, I'll eat 12. It's only once a week, you know. We're looking here, looking to help this person without getting to know them. We're not going to know. Activity. So we don't start off saying, do you do any exercise? Because they're going to go... And you can write down, yes, says yeah. What activities do you enjoy? Yep. Remember, has anybody come across Tim Sharp, the Happiness Institute in Sydney? A few years ago they ran Happiness in Australia on the ABC, and the word exercise stopped people from exercising. When they changed it to activity, it encouraged people. Yeah. So the language is important. What activities do you enjoy? How active is your lifestyle? And, you know, an older lady might say, well, the arthritis stops me walking very much kind of thing. But I do my own washing. I do my own housework. I do gardening. I put my, clothes on the line. Is that an active lifestyle? Absolutely it is. And we need to congratulate people for every tiny little activity that they're doing. Yep.
They use activity, they then tell me they walk the dog and they ride the horse and everything else.
Yep. Absolutely. Hey, such a difference just in a word. So what are the barriers? Is it the pain in the knee? Is it, because the footpath isn't level? What are the barriers here? And then, if we need to, could we include some specific exercise? Could we do 10 minutes of walking 3 times a week? Doesn't matter if it's 1 time a week. If we're getting something happening and a change here, that's important. Once we get that, we can build on it. And are you stable on your feet? Very important that we know. Now, here we go. For our credentialed mental health nurse in the room, I'm very happy that we have this slide here, and I'm very happy that we have you in the room. So, it's really important when we're doing chronic disease management, because chronic illness leads to depression, can be anxiety, can lead to a lot of things, and vice versa, yeah? So we need to include mental health assessment in every single care plan. So what is your daily routine? Because if a person says, well, I kind of get out of my jammies around lunchtime, I watch a bit of telly, what's possibly happening here? Depression, social isolation, yeah? Do you ever feel sad or alone? And they go, yeah, I feel alone all the time. This is possibly a warning sign. That one that says, yeah, everybody gets sad, feel alone sometimes. And that person, then you say, so when you feel like that, what is it that you do? And they'll go, I ring a friend. I go and have a glass of wine. I'll do this, I'll do that. Or they'll say, well, I don't know what to do. We're looking for resilience, yeah? Do you have worries or concerns? Absolutely, we all have worries. But again, it's then when they're there, what do you do? What about your sleep patterns? Do you find it difficult to get to sleep at night time? Do you wake up in the early hours of the morning and you can't get back to sleep? Or do you stay in bed until, 12, 1 o'clock because you don't want to get out of bed? This is really important indicators of mental health illness. And then we have to ask, do you use any substances? Just like that. No other adjectives. What does illicit mean? Is a person maybe going to think, oh, I do, but I better not say, because it's illegal. So if we say, do you use any other substances? And they'll go, oh, like what? And it's like, cocaine, cannabis, methamphetamines, anything over the counter or that you don't get from your doctor. Because what is substance use a sign of? Self-medication for mental health illness, yep. And then you have to ask, have you ever harmed yourself? Yes, no. If it's yes, we need to explore a little bit further. Then you have to be very specific and say, have you ever thought of killing yourself? And you need to use those words. Because if you think that have you ever harmed yourself is going to bring out suicidality, not necessarily, yeah? And it's really important that we ask these questions. Look, when I first started doing it, I'm not a mental health nurse. You know, when I first started doing it, I used to stutter and stammer. My palms started to sweat when I got to this box on the template and all of that. But then it becomes second nature. Once you get to practice, it comes. Absolutely. Absolutely. Because, you know, it happened to me, and it was one of the first or second times that I'd include mental health, and I was talking to a chap, and he was a little bit quiet, and I'd never met him before, and I said, have you ever thought of killing yourself? And he said, yes. And it was like, shit, now what do I do? And, you know, you tick, tick, tick in the mind trying to get the photo of what the words were, and it's like, you know, have you devised a plan on how you would do that? And he's like, yeah, I would hang myself. And it's like, oh, no, you're supposed to say no. You know, like, you know, this is going to be a take a prisoner situation. So the next step, and it was, you know, do you actually have the means? Do you actually have the rope at home? And he said, yeah, I've come in today and to say my goodbyes. This is my final thing for the day. I've waited for my wife to take the kids away to Canberra, and the noose is hanging in the shed at home. And it's like, well, this care plan's going to stop kind of thing, isn't it? But, you know, it gives me cold shivers now thinking about it, that was, you know, saved that person just by being brave enough to ask the questions. You know, I mean, for me, it was like, oh my God, I want to panic, you know. And I said, so if you can just sit here for a minute, I just need to go and talk with the GP because I just needed out of that room, you know. I really did. You know, it's like, oh, you know, and we got the GP and we got the family and turned them around. The police went over there and got rid of the noose and, you know, got the mental health care plan and we got the system in place. But that family could have come home in 3 days' time to find the hubby and their dad hanging in the shed after he had walked out of general practice. Because suicide happens after people walk out of general practice.
So I had a patient a couple of weeks ago who's very similar situation, and of course it's at the end of the day.
Yep.
So it's like 4:30, 5 o'clock. And I've talked to the GP, and we've run the CAT team, and we've run the CAT team, and we've run the CAT team, and there was nothing. And that patient that night went home and, OD'd on medication. So, you know, it's very difficult, I think, sometimes, our role as practice nurses.
Yeah.
You know, because your hands are tied.
Yeah.
What do you do in that situation?
Yeah.
And he was, you know, he's one of those men you're talking about, doesn't have family, home, you know.
Yeah.
So it's very difficult to...
And it comes back, doesn't it? So what did I say there early in the beginning? General practice is a team. There's a nurse and a GP. So when the GP's unsure of how to approach this, they can get the help with the nurse and vice versa. Anything else that we want to add to?
There was two things, just in relation to the lady that was just speaking about the patient that's been on OD. One of the things we can do if you come across a situation like that and you find you're unsuccessful getting hold of the captain is call an ambulance and then link an ambulance and take it straight to an ambulance.
In New South Wales, there's a 1-800 mental health line now too that takes you direct to the hospital in your area and your mental health team. That's in New South Wales. Not sure about other states. So there are other things. And this is important work for general practice nurses, isn't it? We've got to know what services are available. If we don't know, how can we refer to them? Yep.
Sorry, just going back to your other slide. If you come across a patient who's utilising substances and they talk about utilising methamphetamine or they've got a long history of cannabis use and stuff like that, start to explore whether they're actually experiencing any psychosis. Because it's really important, because a lot of patients won't reveal that to a GP because they're coming totally irrelevant related to their health. But if they are utilising and have utilised marijuana or they're utilising ice or methamphetamine or cocaine maybe, and they start to explore if they're experiencing anything that's strange. Okay, because that's quite often a key symptom of either drug-induced psychosis or prodromal symptoms for drug-induced psychosis.
Fabulous, thank you for that. Okay, so medical guidelines now. So these are the sections on my template where I do bring the medical guidelines in, but this is really where I focus. Cardiovascular. I'm going to bring it all together in my head and on my template to say, are we meeting the targets and where are areas that we're not and what can we do? So what is the lipid profile? What are the triglycerides? How are the LFTs? What's the HbA1c? You know, thinking again about the blood pressure, the pulse, the INR. Is it all coming into line? Are they on a statin? Are they on an antiplatelet, you know? Or dual therapy if they need be. Is it warfarin that they're on? You know, ED. What does ED stand for? Fabulous. So why do we want to know whether or not it's working in the bedroom? Absolutely. The penis is a barometer of the heart. Viagra taught us that. Yeah. So we need to include erectile dysfunction questioning in our assessment because it might be the key. ECG. We're going to do an ECG. I'm not going to do one today with a care plan. I haven't got time. But am I going to do one? How often are we going to do one? Annually? As necessary? Other takers? Significant change, yeah. I like to do them annually. I come from rural intensive care. I love ECGs. Never underestimate a normal ECG. Yeah? And as they're ageing, I want to see if their PR interval is elongating. I want to see if their QRS is starting to widen. Because sick sinus syndrome, these people fall and break their hip and sometimes they fall and break the other hip and it goes on for 1-2 years. And if we'd just done an ECG, we could have seen that everything was just a goddamn bit too slow here and a bit too wide and they needed a pacemaker. It's up to your practice and your GPs, but I like to do an ECG annually. Oh yes, absolutely. Good point, thank you. Yep, the QT syndrome is very important for our mental health. So what I'm trying to say is don't go back to your GPs and say, that nurse said that we have to do an annual ECG and she came from intensive care. Because, oh, gee, that's going to get up their nose. It certainly does in our area because, you know, in intensive care, the GPs weren't allowed to step a foot through the front door. They really weren't. If they wanted to see their patient, they had to ring the specialist and make an appointment to actually get permission to speak to the nun to get their foot in the front door. So, you know, try a different way. Is there benefit, you know, to an ECG? Yeah? Think about the way that we speak. So really important that you bring this all home in your head in the context of cardiovascular. We've looked at it all in the bits and pieces and stuff, but if we don't bring it together, then we could miss something. Same for renal. Renal protection, really important. And I think this diagram just shows how intricate the kidney is. Yeah? So what is their EGFR? Is there albumin in the urine? What is the ACR? What are their UECs? I'm really keen to see what their potassium is, particularly if they're on DIG, particularly if they're on Lasix, particularly if they're on an ACE inhibitor. I want to track who are the people that I want to look at the sodium in. Renal failure. It's a group that we've talked about a few times. Diabetes. Does long-term metformin impact on the sodium? No. Antidepressants do, in a major way. Yep, absolutely. So your people with mental health illness, you need to track their sodium. Blood pressure. Is this blood pressure in line with the EGFR and the ACR? Really important. Are they on an ACE or an ARB? Are they on a non-steroidal? Because sometimes they are taking a non-steroidal when it would be better for their kidneys not to. And sometimes that's Nurofen over the counter that we don't even know about, yep? So again, it brings back to the health literacy. We're going to improve the health literacy by educating this person, even when they're not really sure that they need it. We're also, for every person, we're going to look at the eyes, aren't we? We're going to get the optometrist on board here. We're going to have a look at the feet. So I'm not doing the eye test and I'm not checking the feet here. I'm doing a care plan, yeah? But I'm working out, do I need to refer off to this, yeah? You know, you have a look. You know, if the lower legs don't have much of, hair on them, then it's likely that there's arterial disease. You know, you ask, how are your feet? Person with cardiac illness, how good are they at bending down to do their nails? Not always a good thing for them to do, yeah? So sometimes they need the podiatrist, and think about the cognition, think about the ventilation. So I had an 80-year-old chap one time, and I said to him back on the mental health slide about substance use, and he's like, the doctor's put you up to this, hasn't he? I only told the doctor last week that I've smoked a joint every night for the last 50-odd years. He's done this, hasn't he? Why has it worried him so much when I'm already this age? This is how he's approaching. And it's like, geez, I wish I didn't ask that question here kind of thing. And, and it's like too much information. He's like, none of that stuff under lights or anything. My daughter grows it, up Middle Creek. The Creek 3, the one, you've got to use your tinny. You can't walk to it. And it's like, oh. And he's like, why is it such a... And it's like, is this paranoia from his long-term cannabis use? Or is this paranoia because of dementia? So it's like, right, tick box, we need to do a mini mental here, and we can do his over 75 health assessment a little bit earlier than planned, yeah? And don't forget the lungs. If a person smokes, spirometry, spirometry, spirometry. The most powerful tool you can get to stop any sort. Okay. We're going to go through the medications again, not the whole screen, but we're going to say, are we, is this person, do they know what they're taking, why they're taking it, what to do if they forget to take it, and what side effects to look for. It's not about compliance. We're about person-centred, yep? Not about compliance. Are they taking any other therapies that we're not aware about? As we've said, the pharmacist, do we need the HMR? Vaccination, we're great at flu shots, aren't we? What else do we need to think about? Tet-tox? Pneumovax, yeah? So Pneumovax is recommended, not funded, but recommended in everyone with cardiac, renal, alcohol misuse or alcohol use, any pulmonary illness and diabetes. So I remember it as crapped, yeah? So it's recommended. It might not be funded, but it's recommended. It's not an expensive vaccine. We get too focused on what's funded, yeah? So we also need to think about Hep B. Hep B became free in New South Wales in 2011 to everybody in the book. Every single person. Adult Hep B stocks in your fridge. Get it out there. Get it out there. Get it out there. It is a lot of people in New South Wales don't know, so I'd actually ask my public health unit.
That's the only state, no other state that I know of.
I would specifically ask the question of the public health unit. I really would. So Hep B is another really important one because it's all emergency workers, it's childcare workers, it's all of that. We've talked about the DTPA and we know measles, mumps, rubella. Yep, measles, mumps, rubella, and the new zoster vaccine is now being funded for over 70. Okay, so collaboration. It is, as we said,